All right, I think we can get underway. I'm Paul Dazan here for the Education Committee of the Academy, and thank you for joining our monthly webinar. We have a special treat today. Dr. Sue Swedo has been studying autoimmune effects in psychiatry for many decades. This is a very exciting area of current CL practice. But of course, this is a pioneer who has been working in that area, not for a few years, but for a few decades. Dr. Swedo did her MD at Southern Illinois, trained in pediatrics at Northwestern, and then went to work in a fellowship with Judith Rappaport at the NIH. And she was there for several decades, rising to be the founding director for the NIMH Division of Pediatric Translational Research. She's now Emeritus at the NIH, but continues to be active both in clinical work and in advocacy. I think that's all I need to say by way of introduction. If you have questions, please put them in the Q&A, and at the end of the half hour, our speaker will attempt to answer your questions. Thanks so much.
Thank you. What a wonderful opportunity to talk with you about pediatric OCD, PANDAs and PANS. And Paul, I really appreciate the invitation. It's an honor to be with you today. I put pediatric OCD in quotation marks because there's really nothing much new about OCD. Hopefully you're getting your patients referred for cognitive behavior therapy, specifically exposure with response prevention. That in the combination or alone is most effective in the treatment of obsessive compulsive disorder in children. Obviously an SSRI can be helpful as well. We're really going to focus today on PANDAs and PANS. And I'm going to start with just going over their names and why did we come up with these silly acronyms. Then we're going to talk a bit about what's not new, and then finally end up with what's new. And hopefully I'll get it done in around 20 minutes, and we'll have lots of time for questions and discussion. I just came back from the American Academy of Pediatrics meeting and had an opportunity to meet with hundreds of pediatricians, and definitely the questions were of two flavors. One was my patient has classic symptoms of PANDAs and what do I do? But the other one, and possibly more common, was my patient's family thinks that they have PANDAs. How do I determine if they do? And if they don't, what could it be? So we're going to spend a little bit of time on that towards the end. But let's start with what's in a name. And PANDAs is the acronym for Pediatric Autoimmune Neuropsychiatric Disorder associated with Streptococcal Infection. As a retiree, I can do a lot of retrospective thinking, and I think if I could relive my life, we probably would have stuck with anti-neuronal antibody-mediated neuropsychiatric disorders of childhood. Maybe it would have been less controversial, and it certainly would have been recognized much sooner as a form of autoimmune encephalitis. But the reason we chose PANDAs is because we really were focused on that association with strep infections. Dr. Rappaport had been looking for medical models for obsessive compulsive disorder and had really hit on Sydenham chorea as a potential medical model. As I'm sure you know, Sydenham chorea is the neurologic manifestation of acute rheumatic fever, and as such has been documented as a non-separative sequelae of group A strep. So through a series of clinical observations, more recently, epidemiologic studies from Denmark and elsewhere have really documented very tight correlation between infections with group A strep and increased rates of tics, as well as obsessive compulsive disorder. We knew that treatment of strep was able to reduce exacerbations in a small cohort of children with OCD. And studies at the NIMH and elsewhere have shown that you can prevent future episodes of PANDAs with effective antibiotic prophylaxis. In contrast, cross-reactive antibodies are present. We're going to talk a little bit more about that under the what's new category, as we will with animal models. But there really seem to be these 5 lines of evidence to document that PANDAs was an appropriate acronym standing for Pediatric Autoimmune Neuropsychiatric Disorder associated with strep. Here is that animal model, and it's definitely something new. As you can see, there's a PNAS paper published in 2020. The group at Columbia under Duncan Agalu's direction is continuing to look at this intranasal rodent model for understanding cell-mediated immunity. But what they did was not inject, they actually infected the nasal-associated lymphoid tissue, or the NALT, of a mouse 4 times, once a week. And after the 4th time, they found that strep-specific T cells were produced that tracked along the olfactory nerve to the base of the brain. And that these T cell phenotypes were not only strep-specific, but had the ability to produce neuroinflammatory changes within the central nervous system. Well, the second question about the name is whether PANDAS is actually an autoimmune disorder. And here our support comes from clinical observations as well as research investigations. And most of them on this slide are the clinical, showing that multiple domains are impacted. We're going to talk about this more when we talk about rebranding PANDAS as basal ganglia autoimmune encephalitis. But the fact that you have somatic, cognitive, emotional, as well as behavioral symptomatology is really quite influencing there. EEG abnormalities consistent with encephalopathy, as were PSG abnormalities consistent with basal ganglia dysfunction. And immunomodulatory therapies were able to improve PANDAS, but not non-PANDAS OCD and tics. And the 2005 paper by Nicholson, Nicolson, is probably the most important piece of evidence here, because using exactly the same protocol that we had found 65% reduction in symptom severity with plasmapheresis in a group of children with PANDAS symptomatology and meeting PANDAS criteria, 0 out of 5 children with non-PANDAS obsessive compulsive disorder of equal severity had any type of response. So even plasmapheresis does not give you a placebo response in this cohort of patients. MRI and PET abnormalities both were found to resolve following successful immune therapy. And so pulling all these together in conjunction with finding anti-neuronal antibodies, here slides shown of the caudate nucleus, in which you have similar staining of patients' sera who either had Sydenham chorea or met criteria for PANDAS, and not controls, and again, not non-PANDAS Tourette's and OCD. So there really is a very distinct difference between children who meet those PANDAS criteria, i.e. they have incredibly sudden onset of symptoms in multiple domains. PANDAS requires that you also have prepubertal onset of symptomatology and that there be a preceding strep infection or exposure. And more recently, Chris Pittenger and his colleagues at Yale University have documented the presence of antibodies to cholinergic interneurons in acute sera samples from PANDAS patients, again, absent in convalescent sera, and importantly, finding that these antibodies caused a functional perturbation of the cholinergic interneurons. And this paper was published in the American Journal of Psychiatry last year. Excuse me. So altogether, there's more than a dozen different studies documenting the presence of autoantibody-mediated neuroinflammation. These are all the animal model studies. And here, perhaps the most convincing is an older study from Yada Panudi and colleagues, which documented that passive transfer of the strep antibodies was able to produce behavioral disturbances in a mouse model. And what this group then at UC Irvine had done was to take sera from our PANDAS patients, injected into a group of mice. They produced these backflips, hyperactivity, repetitive behaviors. And in retrospect, they actually also produced some anorexia in these mice. And then they took the sera from those affected mice, injected into donor mice, and found that the same thing happened. So definitely serum transport. And that is the last of Witebsky's criteria for documenting a humoral immune dysfunction. So what's in a name? PANDAS, I think it really does live up to its name. Pediatric Autoimmune Neuropsychiatric Disorder Associated with Strep. What was the problem with it? Research criteria require you to have 2 episodes before you can even get a diagnosis of PANDAS. And obviously, trying to find that association with strep is problematic because the group A strep that's most virulent for producing post-strep sequelae, like rheumatic fever, is actually almost avirulent for producing sore throats. So the kids don't have a pharyngitis, they don't get the headache, stomachache, fever that you typically associate with a group A strep infection in a grade school age child. And because it's an asymptomatic infection, it goes undiagnosed and untreated. And consequently, you can't make that connection. That and the fact that we began to recognize that more and more things besides strep could trigger this phenomenon led to a committee meeting in which we discussed what should be done to try and address the problems of acute onset symptomatology. And the result was a definition of pediatric acute onset neuropsychiatric syndrome. In 2014, a group of investigators and clinicians got together at Stanford University, further defined these criteria, and really went to great lengths to publish suggestions for how to do a diagnostic workup that would separate the PANS group from the garden variety OCD, tics, anxiety disorder, and other things that are caught within that. And that paper is available in the Journal of Child and Adolescent Psychopharmacology in 2015, with Kiki Chang as the first author. But the bottom line is that PANS is a very simple clinical diagnosis that describes a syndrome. And remember, syndromes are just collection of symptoms that hang together with some consistency. So PANS as a syndrome requires you to have an unusually abrupt and obvious acute symptom onset, where we did not specify, but I do specify that you must go from baseline to sort of maximum symptom severity within 24 to 48 hours. Now, your symptoms are going to change over time. So you go from this initial hyper-aroused, hyper-vigilant, very anxious, deer in the headlights appearance in conjunction with either obsessive-compulsive symptomatology or acute restrictions of food or fluid intake. And in retrospective studies of our PANDAS patients, we found that somewhere between 1/4 and 1/2 of the PANDAS patients did have concomitant food or fluid intake restrictions at the time, not necessarily related to contamination fears. This is really important to distinguish. If it's a contamination fear that's giving rise to the OCD, I probably wouldn't diagnose them with ARFID, avoidant restrictive food intake disorder. I would leave it at obsessive compulsive disorder with contamination fears. But many of the children didn't even have any contamination fears or other obsessional explanations for their sudden and very dramatic refusal to eat or take in fluids. And in that case, that independent diagnosis would suffice as a primary symptom of PANS. And then they have to have at least 2 of the other categories that include the anxiety symptoms, emotional ability, irritability, aggression, rages, behavioral regressions, extreme developmental regression to the point where an 8-year-old suddenly might be talking baby talk, wanting to play with an infant sibling toys, needing to sleep with their parent, which might be separation anxiety, but also might be that behavioral regression. And then to me, the pathognomonic sign is actually urinary frequency, urgency, and secondary enuresis. We'll talk more about that in a moment. Academic difficulties come from the fact that the child suddenly has an inability to concentrate. Working memory seems to be affected. There are visual spatial skills deficits present, as documented by Tanya Murphy and others, in which they're unable to copy the complex figure of the Ray Oster's task. And they also might have an abrupt onset of hyperactivity or worsening of a premorbid ADHD. And then finally, motoric or sensory abnormalities. Some of our children have extreme light sensitivity, sound sensitivities, textures, and tactile sensitivities. Or they might have the presence of a new onset of tics, choreiform movements, or myoclonic jerks. Here are those comorbid symptoms. I said they need at least 2 of the 7 categories. And as you can see with the percentages, 80, 90, 70%, most of the children had at least 3 or 4 of the 7 categories affected. In this early cohort, 20% met criteria for an eating disorder, And very important to recognize, 10% of the children have auditory or visual or both hallucinations. I promised to come back to the urinary symptomatology. I think this is the pathognomonic sign for the PANS-PANDAS group because it is so unique and so distinctive. And it's present in the majority of children, if not closer to 70 to 80%. Excuse me a moment. Tanya Murphy found that up to 60% of children had excessive daytime urinary frequency. In the absence of dysuria, fever, or incontinence, we actually went back and looked. A 2002 report from a general pediatrics clinic found 12 out of their 3,000 patients had had symptoms consistent with PANDAS during the year prior to about doing the retrospective review. Of that, 8 of the children actually presented with urinary frequency or urgency and had had a workup for a urinary tract infection. Urinalysis was normal, cultures were negative. These very astute clinicians went back, did throat cultures, which were positive, treated the children with antibiotics for the group A strep, and symptoms resolved. But in our more clinically significant group of patients with PANDAS, what you're going to hear is that a child who's been dry for years is suddenly wetting the bed again, or they're having daytime accidents. The children who are old enough will be hiding the fact that they have had daytime enuresis, but they often can't hide the fact that they're going to the bathroom 5, 10, 15, even 20 or times or more to void. And it appears that this may be because of the differential innervation of the external sphincter and the internal sphincter. And normally, continence is maintained by tone of the internal as well as the external sphincter, and voluntary release of the external results in involuntary release of the internal. In our PANDAS patients, it appears that perhaps the internal sphincter is atonic, and so they actually have urine entering that small space, and that gives them that feeling of urgency. One boy described it beautifully. I go to the bathroom, I pee, and almost as soon as I get to the bathroom door, I feel like I have to go again. So if you get that symptomatology, ask about OCD. It remains a disorder of rational irrationality, and the children try to hide their symptoms if at all possible. So that's kind of what's in a name. We're going to start with what's not new, because frankly, PANDAS and the finding of an association between group A strep and obsessive compulsive symptomatology is not new at all. In fact, it is over 140 years old at this point, with the first description that we could find from Sir William Osler describing perseverativeness of behavior in the Korea children, and parents of his patients describing them as a changed child, really reflecting that anxiety, the personality change that some parents talk about. Later, we saw that there was a very tight correlation, and in fact, among Sydenham chorea patients, but not rheumatic carditis patients, 2/3 of them had had an onset of obsessive compulsive symptomatology concomitant with their chorea. I say concomitant when I actually should have said preceding, because in all cases, the obsessions and compulsions started 2 to 4 weeks before the chorea began. So they weren't just a psychological secondary effect of the chorea and the disability that results. They actually represented a perhaps form fruste of Sydenham chorea. Historical links, as you know from the older literature, were just beautifully described in this paper from 1922 and another one from 1926, in which they described cases of Sydenham chorea. And in case number 2, this child developed an abrupt onset of contamination, fears about her food, refusing to eat because she thought the potatoes were filled with fecal material. And in case number 4, she had hallucinations, seeing mice and moving objects in a room, actually thought she saw a man climbing through the window. But interestingly, for 10 days, she had to be tube fed because she thought her food was poisoned. As with these older reports, case number 2, it went on to say, and in between these episodes, she was just a delightful child. Well, also not new is the PANDAS controversy. To be perfectly honest, it started even earlier than this first report. Started at a meeting in 1992 where I presented our findings on the association between Sydenham chorea and OCD. went on to describe patients who did not have any obvious chorea, but did have tics and OCD with an abrupt onset. And almost immediately, the question of, are you sure about what you're seeing, came up. And over the years, it's moved from this doesn't exist to, well, maybe it exists, but if it does, it's rare. And most recently, we're back actually in the current edition of the Red Book that was issued in earlier this year. The report of the Committee on Infectious Disease, once again claiming that PANDAS doesn't exist, that the data for an association with strep and either PANS or PANDAS is as yet dependent on a small and unduplicated number of studies, despite the fact that we were able to provide 250 publications to this committee. In the absence of acute signs and symptoms of pharyngitis, group A strep testing, even by a throat culture, is not recommended. And it's that I object to most, because I've already told you, the strep that causes rheumatic fever, the strep that is associated with PANDAS, does not have symptoms of pharyngitis. They went on to say that there's insufficient evidence to support any of the treatments that are recommended by the PANS Physicians Consortium. And so most primary care physicians, particularly pediatricians, are really left in a rock and a hard place, where if they make the diagnosis, they're going against the, quote, Bible of the AAP, and yet their families are coming in with internet findings and case descriptions that describe their children exactly. So I'm happy to talk more about that during the discussion period. But all I can tell you is this is not a new problem that we're facing. What is new is some very exciting findings. I shared with you already Yale's work on the antibodies against cholinergic interneurons. The Columbia group that had developed that lovely mouse model with the recurrent strep infections has gone on to document that PANDAS sera is able to impact the integrity of the blood-brain barrier. So we are beginning to have an answer of how do these aberrant cross-reactive antibodies get into the brain, which is supposed to be protected space, and set up a neuroinflammatory response. We also are learning from work, frankly, done on long COVID and the neuropsychiatric sequelae of the SARS-CoV-2 infection, that those also can infect the blood-brain barrier, as can the epinephrine release during extreme stress. So the integrity of the blood-brain barrier is not as tight as we were taught when I was in medical school. It isn't as loose as some would imply, because I think that the gut-brain axis that's been proposed, not by any of my colleagues, but by some for PANDAS, is not with support. In fact, we have direct support to argue against it from our research at NIH. However, the new finding is the fact that even in between group A strep infections, children with PANDAS remain vulnerable to exacerbations, in large part because if cross-reactive antibodies are still present, an antigenic stimulus, such as a COVID vaccine, is presented, that it can then reactivate those clones, and anything that then opens the blood-brain barrier allows the antibodies to cross. We now have 2 more studies showing the efficacy of IVIG. You may remember that the NIMH Yale trial was a failed trial. We did not have sufficient power to see a significant difference between the placebo and the IVIG group, although all patients who were treated with IVIG had marked improvement following that open label treatment. And importantly, 80% of the cohort was much or very much improved at 1-year follow-up. As part of that, we still aren't sure at all whether the consortium suggestions that IVIG might be effective for PANS as well as for PANDAS have any basis. There were a few case reports, but no controlled trials. And so under sponsorship of Octapharma, there is a study, placebo-controlled trial of IVIG for PANS underway at multiple centers. And if you have a patient who has had onset of symptoms within the past year, or an exacerbation, there's basically their second episode of PANDAS within the past 6 months, and has not received steroids or other immune therapy for this episode, you might want to consider enrolling them in the ProPAN study. It's just a lovely study, and they're actually looking at the efficacy of multiple doses, although the FDA design study is just for that first initial placebo-controlled comparison. Oops, I skipped one. The clinical course, clinical observations continue to really be augmented through now work at the University of Arizona, at Stanford, at other sites that have established what they're calling autoimmune encephalopathy or PANDAS clinics. And what we have seen from Jenny Frankovich's group at Stanford, where she's following more than 200 children with in-depth analyses, at least quarterly, and reports anytime they relapse, is that children after their first few episodes of an episodic relapsing and remitting course can go on to develop, like patients with multiple sclerosis, a chronic static or chronic progressive course. And that chronic static actually is consistent with what we saw at the NIH in a group of adult men who we were doing brain imaging studies on, but who had an early childhood history that may have been consistent with PANDAS. We've talked just a tiny bit about the impact of the COVID infection on our understanding of what's happening in the neuroimmune sphere, but what is not being talked about very much is the fact that in PANDAS patients, administration of at least the second dose of the vaccine has been associated with some very dramatic flares, often with symptoms as severe as they were initial presentation. Fortunately, group in Texas, as well as Jenny's group at Stanford, has been able to show us that prompt administration of high-dose steroids is effective in reversing that flare. PANDAS cases continue to be missed, but they also continue to be misdiagnosed. And I asked Dr. Discussant to just share that with the question during our discussion period, because I think that that's probably what's greatest interest to you today. And I'm just going to finish my prepared remarks by talking a moment about perhaps it's time to think about PANDAS, not PANS, just PANDAS, as basal ganglia autoimmune encephalitis. As I'm sure you guys in CL know, AE is a very complex set of disorders that antibody positive cases account for only half. So you're always stuck with this conundrum of a person who meets the clinical picture of AE, but you can't find any CSF evidence of autoimmune encephalitis. And therefore, the pediatric as well as the adult autoimmune encephalitis consortiums have determined that AE could be diagnosed on the basis of three things: the clinical presentation, which are now well described for everything from anti-NMDA, anti-potassium, anti-GAD, all of the known antibody positive presentations, as well as abnormalities of paraclinical studies or lab assays. And the third diagnostic clue is actually response to immunomodulatory therapy, much like as we used to do with Kawasaki syndrome, a trial of steroids or a trial of IVIG. The question then becomes, is PANDAS a form of AE? We absolutely have evidence that the clinical presentation fits an encephalolytic process. Paraclinical support, I've shown you a bit of it, MRI, PET ligands documenting inflammation, light up in the caudate and the putamen, EEG and polysomnography abnormalities that resolve with following convalescence, CSF pleocytosis, and this pleocytosis is not an increase in the white cell count, but an increase in the number of atypical lymphs when they are subjected to flow cytometry. And CSF and serum cross-reactive antibodies. We actually have an antibody-positive disease in PANDAS, although there are not any clinically available tests for the autoantibodies of PANDAS today. And then finally, improvement with immunomodulatory therapies as that third leg. So I think that, in my opinion, as in that of Russell Dale, it is time to rename PANDAS as basal ganglia autoimmune encephalitis. Paul, did you have a...
Oh, I was just going to say, we've come to the end of our time. The
whole half hour? Oh, no. I'm so sorry.
We've come to the end of our time. The the degree of opposition from pediatrics for this disease has been really striking. And, you know, our audience today faces the same thing with patients with abrupt neuropsychiatric illness, where we may lack a serum antibody to persuade our neurology colleagues to provide the immunomodulatory therapy, which then, once applied, is actually successful. So it's great for our audience to hear the story. Thank you so much. And of course, we post the recording, and especially this last slide, I think, is very important for those looking for help. Thanks.
And I apologize for running out of time of questions.
Oh, no problem.
If you want to send them to Dr. Discussant, I'm happy to answer them offline.
Oh, okay, very good. Thank you. Bye-bye.
Bye.